You put on.
Okay, welcome back from the meal break. We have a special guest presenter. Simon, you want to do the intro?
Can you big screen that one? So we're very fortunate to have Dr. Susan Hsieh, who is a pediatric dentist who works in Sydney here. She has a specialist interest in integrative approaches to optimizing oral health through oral posture, nutrition, growth guidance, and surgical intervention when necessary. So one of the journey pathways that she has done has been shared with myself with the progressive orthodontic seminars, training in traditional conventional orthodontics, bifunctional orthodontics with Dr. John Flutter and Germain Ramez-Yanez, along with Dr. Suriz Zaghi, an ENT who specializes in phrenectoplasty, and now with me in the Postural Orthodontics program. So she herself has 2 children, 9.5 and 11, and they've benefited from the program that Susan was part of with my mentorship and helping to develop using my widgets, my exercises, some changes, some positive changes in the growth and development. What we are hoping to do is share some of Susan's experiences as a specialist and also as a student of mine in the mentorship program. So what we're going to do is let her present, but we're just going to change over so I can pass her the mic, and if you can let me share screen.
Thank you. Okay, does everyone hear me okay? Just wait, yeah.
Yes, loud and clear.
Simon.
Hi, Susan.
Yep.
Welcome.
Hi. So thank you for inviting me, Simon, to share my experience as a clinician. And it's worth noting that actually I was one of the original batches in the advanced mentorship. So I'm still actually part of that mentorship, and it's been really invaluable in not just the treatment of obviously my own children who will present shortly, but also just the ongoing care of my patients, not just in the postural orthodontic side of things, but it's been really I've been very fortunate also to be mentored through essentially the COVID years on dentistry in general. So that's been really invaluable. I thought I would present the cases of my children going through and how the evolution of going from, just correcting some of the habits that they had into some other sort of tools that we had and then into postural orthodontics. So from the viewpoint of a treating clinician as well as a parent. So let's kick off with the genesis or the beginning. So this is what I would be greeted with every afternoon at the end of a busy day. Both kids sucking their thumbs, really enjoying themselves at the end of a busy day. So needless to say, I had an inkling that they would probably need something at some point. Being a pediatric dentist, I knew that they would have some issues with growth and development, and that the habit would be something that we would have to address. And if, I think so, let me try again. Maybe not. I might just, yeah. I can just use the. Okay, so if it's all to do with genetics, what hope did they really have? So this is my husband and their father. So you can see, very obvious class 2. And here's a picture of me as a baby, and many photos of me with my mouth hanging open. The option was either tongue out or in. And so this was the combination in the genetics that were gifted with. So ultimately, would there be any point trying to do something early? So let's kick off with the story of my firstborn. And so thumb sucking. It was actually here, exactly here when she was at age 4, when I learned from Germain Ramez-Yanez that one of the options for reducing thumb sucking was using a fairly simple technique of, cutting a straw roughly to the length of the size of the thumb, and then using a Band-Aid and sticking it on as a reminder to try and stop thumb sucking. And the idea that if it's a habit, it takes about 28 days for humans to kick a habit. And if it's an insidious habit, you kind of need to double that time. And so with that principle in mind, what we did was I gave her a choice of different colors and different Band-Aids, and so that she would have the illusion of control. And the only request that I had for her was that just keep it on. I didn't mention anything about not putting a thumb in, not doing this and that. We tackled the daytime habit first, and once in about 2 weeks, we noticed that that habit had dropped. And then we tackled the nighttime, and we kept this on for a good 8 weeks, and that was it was successful. So that was great. And then we moved on to sort of the MyBrace protocol and Planner's tracks, which is also something I learnt from Herman. So this is kind of a before and after, and we see positive changes. We see a deep bite that where we jack the bite open a little bit, and in the space of 4 months, when you treat young, you can see quite decent changes in a fairly short amount of time. And you can see from the side profile. And again, that's lower jaw coming forward by the Planner's tracks, and as well as wearing the MyBrace. It's worth noting both my children have enamel hypomineralization, so their teeth, you can see the quality of the teeth isn't too great there. And we'll point out some hygiene issues later in my own kids. When it's blown up this big, it's kind of like horrifying for a pediatric dentist. But anyway, that's okay. Let's keep moving. We're not here about oral hygiene. So the occlusal picture, look, we probably didn't expect huge changes from MyBrace alone on the actual, trying to get some transverse and AP changes. And you can pretty much see a nice thumbprint that's been formed there over the years from utero. Mind you, we saw the thumb sucking in utero. So this is a habit that's been there for a long time. But you can sort of just even eyeball that and know that we're probably going to have issues with the permanent teeth. But I was just happy to kick the habit of the thumb sucking to begin with. And the lowers, again, some sort of mild alignment issues, and so that's worthwhile noting that we've got some positive changes in about the 4 months. The profile change. So interestingly, her chubby little sort of cheeks, the strong cheeks, dropped from the thumb sucking habit dropping. So one thing I have found that in my hands, I feel like the MyBrace is a great habit breaking appliance, and cutting the habit was a big thing. So again, the face for me, most noticeable sort of change was around at that point, and you'll see it as we go along, as we kept going. Now, I have to go back a little. Can I go back? Yeah. So this, as we said from the occlusal pictures, we know that when a permanent teeth came through, we knew it was going to fit, and rightly so. You can see the picture on the left before and after. Okay, so by now I knew we would be using the bi-block. So I had training in bi-block, and I was using it at that point. I had stopped using the lower bi-block at this stage because I just found in my hands it wasn't particularly predictable at giving me any sort of transverse or correcting the curve of Wilson. But ultimately, just using something that I knew, which is the lower Schwartz, I still got some more space. So the goal here in my head at that time was like, okay, let's just try and fit these permanent teeth in place. And you can see from the side profile, again, just some AP changes, some hygiene issues, and some AP changes. And so again, just, some nice changes over, again, 4 months. So this is a short period of time. And again, occlusally, so nice enamel hypomin there. But again, just generally, good transverse, fair bit of tipping again. So this is one thing that and you'll learn this as you go along when you look back at your old treatment pages and you think, oh gosh, okay. So there's a lot of tipping on the right-hand side. And now that I've been in mentorship with Simon for these few years, I can see things that I see now that I would do differently. And certainly sort of in the bottom, you can see the alignment on the incisors on the right. There's a missed opportunity there for alignment at the time. So again, learning to bend wires, using appliances well, and using appliances that are made so that you can bend the wire to your heart's design. No, it's not going to break. That's been really important. So that was the journeys at that point. So So during her early mixed dentition phase, we then did upper bi-block, lower shorts, and you can sort of see some, not huge changes in the face and going. So then I think around this time after that phase of treatment, I heard about Simon, not so much that he was doing a course on postural orthodontics, but certainly I had heard about good oral posture exercises. And then around, I think before COVID closures hit, we then had the course that was, it was by Zoom at that time because of all the closures. But anyway, so moving on, this is again before and after. So essentially she was in postural orthodontics for about a year. You can see some nice changes frontally again, but I think the more profound changes came from the profile shots. So, and again, so looking at, she wasn't too bad to begin with, but once that we actually started postural orthodontics, that she definitely got a lot more change in the AP, which was, something we were looking for. And again, so you can sort of see before and after. One thing of note is that my photos also improved because Simon does tend to, make sure that you get the best out of all your records as well. Now, my before and after here, look, I didn't treat her with the intention of presenting this at some point. So again, that was the before I had. So I took a photo of her casts, and again, so got some nice, again, mainly AP changes, and she was in mixed dentition, late mixed dentition by the time that she finished. And we kind of needed to get rid of all the appliances by then, just so that the spaces were closing and letting her develop. So you can see the tongue fits in nicely. And if anyone's curious about the examples, so I was one of those students that, I know I'm about to do a course, let's jump the gun and start treating my own kids. And then, I'll wing it at that point. So the design on the left isn't quite what Simon would advocate. So we're missing some rests on the canines and some other components. So that's what I did. So again, just a note, if you're going to do this and do the mentorship, it's good to listen to the teacher. And the Mu stage 2 is it's almost like the retention part of it. And again, looking at it on a big screen, I can sort of see, I didn't adapt those wires all that well at that point. But again, all these things you learn through mentorship is like, it seems like little things, but it actually does make a big difference, if you're treating over a long period of time, as well as multiple kids. And these are examples of Wong stage 1 and 2. So on the bottom left, that's probably a little bit more standardized, although the labial bow could be more closely adapted. And so looking at this, the great thing is that the screw that we're talking about, this is these are both appliances by Rinko as well. So one thing that I do know, because I haven't obviously gone through multiple tools so far, I have found these wires a lot more predictable in bending. I just didn't find they broke all that easily. So that's been good. And the solder, has held up really well. So again, profile changes. So generally getting better. So you can sort of see that sort of getting a little bit more little adult-like in her facial structures as well. So losing the sort of strong cheeks. And again, period of a year. So always curious when I see, lectures about sort of growth and development. I try and do the 12-month follow-up, and there's actually a 2-year follow-up as well, which I took recently. So this is just, again, no appliances, retention purely only by good oral posture exercises. And so that's the photos. You can see sort of profile shot. Again, no retention, tongue space, inhabits that space well. And teeth are settling, hygiene. Anyway, when I see in such big blown up pictures, it's anyway. And you can sort of see closely that, things are stable. So that's what we're looking at. So, and then again, this is at 2 years. So again, no appliances. We have slacked off a little bit on the go effects, and this is what you find as we hit the tweens. But again, it's, things are relatively stable for her. And mind you, she was growing relatively well to begin with. My second born is a slightly different story, but you'll see that journey very shortly. And again, things are looking stable. Tongue inhabits the space well. And resting posture is essentially lips together. And again, teeth settling nicely. So again, without retention. So after seeing some of the pictures, though, I do know that I'm going to go back to some of her basic exercises again, the Go Face. So again, what was different this time? So having gone through, you know, the Maya brace protocol and then the sort of the appliances only protocol, I think what made a big difference is that I had the end picture in mind. And the end picture was that when she's at rest, her lips together, teeth are in light contact, tongue is on the roof of the mouth. And the whole point of these exercises is to get to that point, not just for the exercises. And as I said, I kind of came across Simon's work a little bit earlier on than before I actually did the course. So I think I was looking for, you know, my functional therapy exercises and came across this. I found it very practical because you're doing it in, you know, kids aren't going to stop eating or talking. So it was relatively easy to incorporate into our lives. And so what I did was that at the start of a meal, I'd actually have a timer at the side of the table and it had a pig face attached to it. So rather than being the nagging mother, I'd be like, look at the pig, the time is not finished, the time is not finished. So they knew they had to sit up straight, chew their food until it's liquid and take a pause when they're about to swallow, teeth and lips together. So that was kind of the mindful eating side of things. Reading out loud, probably more useful if you've got kids in primary school where they've got home readers and they have to read anyway. So one thing I always say, it's really good for public speaking and fluency. So these are words, like keywords like, oh, okay, this is going to help in something else. So I think that has been useful. And the idea is that when you're reading, you put the text at the level that helps you maintain good posture and core muscle strength. And then you read and phrase. So every time you see a comma or a full stop, you pause, teeth and lips together, and then you keep reading again. So, you know, and it's been helpful. Yeah, so she's been doing well in public speaking, so I must have done something. Now, so, you know, we all sort of know it's hard to maintain these exercises. And for those who are trying to keep fit, you know what I'm saying. So the beauty of it is like it's specific, short little tasks. It's measurable. You can see the changes as they get better and better. It's obviously attainable. You're doing things, you know, you're eating, you're talking already, and it's time-based. So we give them sort of little, you know, try and aim for a month, and then give them different tasks. So that's been really quite easy. Helpful when the family's all on board. So mindful eating is really lonely if you're doing just one kid and one parent watching them. So they don't really have to, you know, bounce off each other. So luckily my kids kind of did all these treatments together, so they helped each other. There are obviously days when they don't do what they're meant to do. So there's, you know, they don't wear their posture. If you're not watching them like a hawk, sometimes they just do whatever they want. But again, just being mindful when you pick patients, you know, what does that look like? What is this protocol going to look like in that particular family? Are they likely to be compliant? Do you have to sort of, you know, perhaps pick a different tool? So that's something to note where the diagnosis is so critical. Isn't just like, what tool do I use and what teeth do I move? It's kind of like, is this actually going to work in this family and this child? So as I said, kitty number 2 is slightly different. So we had a lot more issues with probably ear, nose and throat. And when you saw that massive class 2 picture of my husband and his dad, so he took after him in that regard. So I mentioned ear, nose and throat issues, and I note tomorrow there'll be some discussion about nasal irrigation. So this is to give parents hope that if you start, so we started before, I think just before 3. How do I press play on this? Oh, there we go. So we just started before 3, shown him a few YouTube videos of other little kids doing the same thing. And that's probably second time that we've tried it, and obviously not happy. But we explained what it was for. He had seen multiple videos of other kids doing it. His sister insisted on taking a video. So you can sort of see that. And, you know, I said, we'll just do it 3 or 4 times. And literally we'd count, we'd do it, squit. So one thing is that if they can see what's coming out of their nose, which is snot and God knows what, even when they're not sick, it kind of then makes them connect that this is necessary, this is helpful. He hated it. It was awful. But the great thing about this is then if you get used to it enough, let me try and go to the next one. Yes, well, yes, it's just professing. Yes, well, tough. Yes, so, but if you persevere, like most things in life, right? If you persevere, and this is, it gets to this point, like he actually, it's like he mixes his own cocktail beforehand and then goes to the bathroom and does it all. So it's, you know, this is at about age 5, yes, age 5 at this point. So you start early enough and you sort of reiterate how important it is that they do learn, and it's relatively easy. So we didn't obviously have to do this for, we did do this for years and years. And if for anyone who asked me, you know, why didn't you see the ENT? We saw 3 ENTs and 1 immunologist. So their conclusion was 2 of them said, yes, take the adenoids out. The other 2 said, don't. So we kind of just decided, okay, we know he's got allergies, so minimize that. We'll wash his nose. We'll, you know, try and clean the pipes and make him use the pipes correctly. So it's a bit like anything with, for example, postural orthodontics, you're correcting structure so that you're then ultimately teaching the tongue and all that to inhabit the space correctly. So it's not that different when it comes to sort of airway as well. So this is his journey. So both kids had the similar treatment protocol at the same time because it's just easier as a parent just to make them do the same things at the same time. And so his was obviously finishing the habit first. We started nose washing and allergy minimization, and then myobrace as well. So so we finally got his mouth to close, and his deep bite obviously deepened at that point, because when you've got lips together but teeth wedged between your tongue wedged between your teeth, your bite deepens there. So you can see that there. But you know, he held it in. Again, I treated him not thinking that I'd be presenting this one day, but there you go. So photos before and after. So couldn't take the photos before, and still V-shaped arch. So looking at that treatment at the end of that little treatment protocol, we know he's going to need more stuff, right? So, and you can see the bottom, similar story, massive tongue, doesn't quite fit. So I think the profile shot's really quite telling. So again, you can see before and after, mouth open versus mouth closed. It's I do have to de-identify them, but if you could see the eyes, you can actually see that the cant of the eyes in the before is very much just, you know, that sort of melting face, and it actually evens out in the right side a little bit, but evens out even more as we started more and more expansion. And interestingly, when your nose is so blocked, he had multiple ear infections as well. That was him facing me straight. I said, look at me straight. That's him facing me straight, because obviously balance is out as well. And so again, sorry, jump to the next one. But then what we decided is that, okay, let's just try and treat him in the primary dentition to try and create more space so that his permanent teeth come out straight. So the idea is that we expand, give them lots of transfers. Again, not guided by Simon at that point. I was just doing what I kind of knew at the time. So again, 4 months, big changes. Not like you can't really see it in the profile shots, but you can certainly about to see in the occlusal shots. So if you eyeball that, you know that the permanent teeth will fit in the right side. And you know, some nice changes from the bi block and lower Schwartz. Again, looking at this now, just know that, you know, I could have done more, but again, so just, you know, mentorship and it's really been invaluable there. And profile shots, again, you can sort of see nice growth towards going forward as well, and mount more of lips together, nasal breathing. And frontal, sorry, you know, sometimes these photos are taken the end of a school day plus daycare. I mean, not daycare, after school care. So yeah, they're a bit jack of me taking photos. And so then we moved on to postural orthodontics. And again, this is actually where, in a case like this, he had that class 3 tendency, he had the midline shift. You know, I think this is where we did quite a lot of things to try and get him from the left to the right. And you can see, you know, centering of the midline. And obviously the relationship is a lot less sort of a class 3 tendency there, and a good AP sort of development. And so this is again before and after. And I have to point out, oh gosh, I hate looking at that. But anyway, so that's from 7 months of kombucha. Okay, so this kid does not get anything else. Can you imagine? But he got kombucha, so 7 months, and that's scary. So it's just for all those who love kombucha. That's something to note. Very low pH. And again, the lowers, you can sort of see before and after, really nice. The tongue fits nicely. And so moving on to some of the examples of the things that we used. So I did use a whole, variable appliances, but one thing I will say is that when we treat it in the primary dentition, when you don't have permanent sixes to actually rest against, it does make it quite difficult to sort of retain well and develop the arch well. So that's just probably something to note. But I suspect his eruption was delayed in his, when compared to the development of his actual arch. And again, so stage 1 is very much with a screw. Yeah. So some of the tools we use in order to actually, we use a Cambo that was relatively well tolerated, and he slept with it and functioned really quite well with it. And Simon taught me sort of the cross elastics using existing little hooks that were already there, and that was really quite helpful. And looking at profile shots, so I think his was more impressive because he started off with quite a class 2 tendency, yeah. So that's I felt like postural orthodontics really changed the trajectory of his growth. I mean, amongst all the other things that we did, but the postural orthodontics, the posture, the understanding of the end game, not just going, okay, I'm trying to straighten his teeth and fit his teeth in. It was like knowing that the end game is that at rest, teeth and lips together, tongue on the roof of the mouth, and breathing effortlessly. So that's the end game. And again, I had to de-identify them, but their eyes did actually, his eyes did actually sort of even out and actually rise up. So that's been really quite positive. So follow-up. So this was recent. So recently took this again, no retainers. The only thing we really did has been the Gopex. And that's I will say, when you're 3 years on, it can be a bit of a struggle. So I do try and change it up and make it more sort of interesting. So just something to note for those who struggle with keeping the exercises up. And again, so the profile. So yeah, so growing generally pretty well. That's intraoral photos. So again, lots of premolars yet to come through, but again, not retained by anything. So other than just essentially exercises and constant nagging from his mother. Again, so this is the upper lower tongue fits well. So that's yeah. And so possible outcomes. So what could he have, I often think to myself, okay, if we didn't really bother with postural orthodontics or any of it, we just got his nose breathing and cut some of his habits, there's every chance he could have been like Dad, every chance. So, because Dad had a similar history, he's had fixed ortho. So, that's every chance he could have become like Dad. So, but fortunately, like we intercepted at different points relatively early, and I learnt lots along the way. And, we got some nice growth and development happening in his case. So yeah, so that's the journey as a parent and as a clinician, and sort of how I kind of came to do postural orthodontics. And I thought I'd end with a picture of, I took this picture because it's the first time that neither of them were snoring. Neither of them had their mouth open, and they were sleeping peacefully. So that was like momentous for me. So I took a photo. I'm working on my dog now. So yes. Yeah, so that's basically my recollections in a nutshell. I did have a little bit on tongue ties, but I don't know if there's much interest or there's time. So I left it in the actual handout itself. It's just mainly because there were some questions about posterior tongue ties, but there's a paper that does it beautifully. You don't really need me to go through that paper. So, but anyway, that's basically in a nutshell. Yeah, thank you.
Wonderful. Q&A time.
Yes, perfect. Thank you so much, Susan. So if you have any questions for Susan online, please type them in the Q&A. And if anyone in the crowd in the Sydney room would like to raise your hand. Simon, you want to bring up? Yes. Yeah, go ahead. There's a gentleman.
Now, when you look back to when both your children were doing thumb sucking, how much of that could you say that had contributed to the issues that were then presented?
Massively. So it would have, but I probably didn't add this. So my daughter actually had quite a severe tongue tie to begin with. So I think that was a contributor as well. But yes, like habits. That's the first thing like you kind of want to cut. So if I did the treatment again, I would still start with removing the habit, but I probably would have done a slightly different order and not. I intercepted several times, and I thought I could have probably done it in shorter spurts and more targeted. But live and learn. So yeah.
Thank you for sharing your perspective. It's so unique coming from you. You've had so many different aspects of training and seeing, your kids go through it as a parent as well. Yeah. So it's really wonderful to see. I'm just curious about how you implement what you know, as well as what you've learned from POS and your Schwartz and your MyoBrace, and how do you incorporate all of those aspects into what you do now? Have you dropped things? What do you keep?
Yeah, good question. So I probably don't treat as many different cases. I think I'm a lot more sort of finite in who I treat as well. So, and that has helped dramatically. I do use some fixed appliances to sort of correct things that where I think like we just need to get in there and get some results so that patient remains really motivated. MyoBrace, I think, was probably the initial. So POS and MyoBrace, I kind of did them concurrently. POS was first. So that taught me kind of understanding of progression of the arch wires and skills, and I still use them for impacted teeth and things like that. So that component's still there. I certainly don't do any of the TADs because that was the component that was also taught. As far as MyoBrace, I think it's a good habit breaker, but I think in very select cases I will use it. But I think generally I find having an appliance in that's essentially really difficult to remove more predictable, because I kind of think that, and what I've learned over time is that kids they will tolerate an appliance really well for probably 6 months, and you will start to lose them. So you don't want to, for me, I felt like I don't want to waste it on the MyoBrace. That's certainly the patient's license anyway. Because and what I hate to say wasted on MyoBrace, it's not wasted, but if I've only got that finite compliance, I'm going to use something that like kind of throws them as much as possible, and that the BioBlock has been, and BioBlock and Widget, those two things I have found probably the most predictable. It's really hard to remove. They can eat with it. They're relatively comfortable. So that's certainly in my hands what I found has been most predictable anyway. So yeah.
And I guess knowing about that window, which again is short, relatively short, like to keep them engaged. When would you have ideally treated your kids?
Okay, so knowing, like, I would have done the habit breaking would have started like at that same time. I think now I think about it, and feel free to interject, but I generally prefer the first permanent molars in place and the central incisors through. So I often say you're at least moving some permanent guideposts into play, rather than shifting sands and then losing that again. So that's again in my hands. So yeah.
Great. Thank you.
Yeah, no worries.
Thank you for sharing. I know that's a lot of compliance and persistence as a parent to do. And it looks like you achieved great results at age 4.5. Is that right, with BioBlock?
Yeah. So that would have been the younger one. Yeah. So
do you treat other people's children at that age? I know that if they don't have permanent molars, you're reluctant.
Yes, they're very select, because I paint a very dreary picture, and then if they still go yes, I will go okay. So I would
qualify them.
You kind of have to, otherwise you'll be like dragging them through. They'll be dragging you through, and it's just sad for everyone involved. So yeah, so that's just, I think that's from experience though. So, yeah.
Great, thank you.
Right. I think there's some online, isn't there? Yeah. Oh yes. Is it from the start? Once you get 7?
Simon, do you want to? I think we're at 8. Question 8. If I haven't bolded it, maybe we finished 8. I think 9 is where you guys are at.
9. Okay. What do you do? I'll see you later.
Yeah, Simon, you want to read it?
Sorry. What? Sorry. coming. What are we doing? There we go.
So the question is, how do you manage the appliance and mixed and, nine, we've already done nine. What do you do when a patient comes in very late, 12, with blocked out canines and a high palate? So one of the things that I've learned is I'm good at some things, but not everything. So I just do what I'm good at. And I have my staff screen out the older children. Parents will ring up and say, "Oh, I've got a problem. I've heard about Dr. Wong. Can we come see him?" And the first question she'll ask is, "How old is she, your child?" And say, "Oh, 12, just turned 12. And you said, "We only see children under the age of 11. But we can't help you." Right? Because teenager with impacted canines needs orthodontists. Right? They just need orthodontics. They have to have it pulled down. They'll want their teeth straight. It's not my job to do early intervention on a 12-year-old. All right, so you want to be successful and do what you're good at, and only do it on the people who meet the criteria. So there was a good question before about, is there a good time to treat? And there is. A sweet spot is 7. Unless it's a significant skeletal malocclusion, then 4 is good. 4 and 5 are good for significant malocclusions, and 7 is great when the first permanent 6s are through and in contact. All right, and then 8 or 9 is fine. But what happens at 10? Yeah, start losing primary teeth. Do you want to be working in quicksand? Do you want to be working in the Sahara where the sands shift overnight? So why make it difficult? There's enough kids between 4 and 9 for you to spend the rest of your life treating. But what if an 18-year-old says, "I'll do whatever it takes if you do early intervention for me. There's nothing I won't do." And I'll say, "What about surgery?" "Oh, no, I won't do that." Yeah, so it's right tools at the right time for the right situation. You have to be very confident in saying, "No, I can't help you." Because you can't. There are other people who can do better work than you can at 12. When you're using programs that are designed for 4, 5, 6, 7, 8-year-olds. All right, it's designed for young children. 12 is not a young child. The next question is, are you using hand clasps? We used to use a class called the Hang class that was designed by Bill Hang, an orthodontist in LA, but we found there's a few problems and we don't use it anymore. So it's a unique design that we created ourselves. It's like a crozet, it's like a hang, it's lots of little tweaks and things. Next question was, what is the age range of protocol? So 4 to about 9. Well, literally, there's a sea of children who are aged between 4 and 9. All right, you can spend your whole working day, 5 days a week, 300 odd days a year. You need a holiday, believe me, right? So why try to do something that isn't designed for the child? Next question is, does Spark follow an airway protocol and expand as much as possible? Spark is an orthodontic aligner appliance, so it's just a tool. You make the decisions. You're the prescribing doctor, right? We're assuming that you are the prescribing doctor, and you aren't relying on your technician to make the decisions of diagnosis for you. And one for you.
Yep. And next question is, why did you consider tongue tie release for your daughter? Actually, if there's a theme across this entire presentation is that I learned and I try on my children. So she's had 3 as a baby. And when I learned about lasers, I tried it with laser. And the final one I learned was Surusagi. So she's had the frenuloplasty. So yes, I did consider it and I performed it. And that's I often tell her, because she had to go through this through awake. And every time I look at her face, she'll go close her mouth and clamp down. But I always tell her, you know, there's a lot of people in Sydney to thank because you went through what you went through. And because I that's actually the probably now the bulk of my practice is actually treating tongue ties. So because, you know, like, because my kids went through it. And also from a parent's point of view, knowing what gagging, choking on food and speech issues and all that kind of looks like. And it can be subtle, but it's there, right? So, yeah. So, yes, in answer to that question. So someone had another hand. Yes. So Surusagi, so Breathe Institute. That's what I found. Again, in my hand, sorry. Yes. California, so LA, yes. So he's an ENT. He's got a whole team of pediatric dentists and oral max facts as well. So yeah. Thank you.
Thank you.
Thank you, Susan. Terrific.
Thank you. Thank you.
Okay, so that ends Susan's section. I'll stop the recording there.